All right, class, let's delve into the fascinating world of the thyroid gland. Picture it as a delicate butterfly-shaped gland, nestled just below the cricoid cartilage, right over the trachea. Under normal circumstances, you won't spot it from the outside, but inside, its follicular cells are hard at work synthesizing and secreting thyroid hormones T3 and T4. Now, what's really intriguing is how the blood vessels within the thyroid gland are intricately wired to our sympathetic and parasympathetic nervous system. Neurotransmitters dance around regulating and secreting hormones and blood flow within the gland. And get this, the thyroid actually stores a 2-month stash of these crucial hormones. But it needs just a tiny bit of iodine, about 1 milligram per week, to keep the production line running smoothly. But let's talk about what happens when things go awry, especially in cultures where dietary iodine deficiencies are more common. In those cases, the blood levels of T3 and T4 take a hit, catching the attention of our trusty hypothalamus. It responds by releasing thyrotropin-releasing hormone, setting off a chain reaction. The anterior pituitary jumps into action, releasing thyroid-stimulating hormone, TSH, which zooms through the bloodstream to the thyroid, prodding it to crank out more T3 and T4. But here's the kicker. Without that necessary iodine, the thyroid struggles to keep up. And TSH? Well, it's not one to give up easily. It keeps pushing, leading to the hypertrophy of follicular cells and eventually the formation of a goiter, a fancy term for an enlarged thyroid gland. Now, let's shift gears and explore the myriad roles of thyroid hormones in our bodies. They're like the conductors of our metabolic orchestra, influencing everything from our basal metabolic rate to how we metabolize lipids and carbohydrates. They even have a say in protein synthesis and breakdown, not to mention the impact on our central nervous system. During fetal development, they're crucial for brain maturation, while in adults, they can sway our moods. Hyperthyroidism, that can leave you feeling jittery and irritable, while hypothyroidism might slow down your memory and speech and cause a little bit of depression. And let's not forget their influence on fertility, ovulation, and menstruation. Oh, and we can't wrap up without mentioning calcitonin, the underappreciated third player in the thyroid hormone lineup. This hormone steps in to regulate blood calcium levels, putting the brakes on bone demineralization. It's even used in medications to treat osteoporosis and osteogenesis imperfecta, a childhood condition characterized by fragile bones. So, as you can see, the thyroid gland and its hormones truly remarkable players in the intricate symphony of our bodies. All right, class, before we delve into the complexities of thyroid dysfunction, let's first understand and evaluate the lab values associated with the thyroid. Now, in some instances, we might analyze thyrotropin-releasing hormone, though it's a rarity in acute care settings. Typically, we focus on thyroid-stimulating hormone, TSH levels, especially when thyroid hormone levels consistently register low, indicating conditions like hypothyroidism. When T3 and T4 hormones are released into the bloodstream, they predominantly bind to a specific plasma protein called thyroxine-binding globulin. It's crucial to note that only the unbound or free T3 is metabolically active, akin to free calcium. Generally, there's less free T3 than free T4. Now, in cases of thyroid dysfunction, both T3 and T4 hormones typically follow the same trend, elevated in hyperthyroidism and decreased in hypothyroidism. These lab values serve as guiding markers for adjusting thyroid medication dosages, and they may slightly deviate from the normal range. However, for patients with undiagnosed thyroid disorders or severe cases of hyper or hypothyroidism, these levels could be drastically altered, providing crucial diagnostic insights. All right, now let's delve into alterations of thyroid function, focusing on Graves' disease, the primary cause of hyperthyroidism. In this condition, thyroid hormone levels are collectively elevated, while TSH, or thyroid stimulating hormone, is decreased, a pattern we often observe in the circle diagram of thyroid function. But here's the intriguing part. Despite the low TSH levels, the thyroid hormones remain relatively high. Why? Well, it's all thanks to thyroid stimulating immunoglobulins, TSIs. These special antibodies essentially override the usual negative feedback loop, compelling the thyroid gland to continue synthesizing and secreting hormones, even when TSH production is suppressed. This persistent stimulation can result in the development of a visible and palpable goiter, a hallmark of Graves' disease. Now, let's talk about some of the distinctive clinical manifestations associated with Graves' disease. Exophthalmos, or the protrusion of the eyeball, occurs due to increased fat deposits behind the eye, inflammation, and weakness of the optic muscles. This bug-eyed appearance can also lead to double vision and corneal ulcers, as the eyelids provide reduced protection. Additionally, individuals with Graves' disease may experience pretibial myxedema, characterized by swelling of the lower leg tissue. Unlike typical fluid-based edema, this swelling is non-pitting, erythematous, and firm to touch, resulting from the redistribution of adipose and mucosal tissues. Now, let's zoom out to the broader picture of thyrotoxicosis, the general term for elevated thyroid hormone levels. This condition triggers increased sympathetic stimulation, leading to a heightened metabolic rate and intolerance to heat. Patients may experience drastic weight loss, rapid heartbeat, tachycardia, excessive sweating, especially on the palms and soles, diarrhea, irritability, insomnia, muscle tremors, and even amenorrhea in females. And remember, when you think of hyperthyroidism, think high and hot. It's characterized by heat intolerance and high metabolic rate. Now, Graves' disease isn't the only cause of hyperthyroidism. Nodular thyroid diseases like toxic multinodular goiter or toxic adenomas can also lead to elevated thyroid hormone levels. Unlike Graves' disease, these conditions aren't autoimmune and don't present with distinctive signs of exophthalmos and pretibial myxedema. And let's not forget about the potential for hyperthyroidism resulting from the overuse of thyroid medications. Now, when it comes to treating Graves' disease or other forms of hyperthyroidism, we have a few options at our disposal. Surgical interventions, pharmacologic treatments, or a combination of both. Collaborating closely with the patient and their healthcare provider, we may opt for a partial or total thyroidectomy, a surgical procedure aimed at removing excess thyroid tissue to curb hormone production. A partial thyroidectomy allows the patient to retain some natural thyroid function, whereas a total thyroidectomy renders them dependent on lifelong thyroid hormone replacement therapy. But how does the surgeon determine the extent of thyroid tissue to remove? Well, the science behind this decision isn't always precise, leading to less than optimal outcomes in some cases. With a total thyroidectomy, the patient's reliance on thyroid hormone replacement therapy becomes inevitable. Another approach involves oral radioactive iodine administration, which targets and destroys thyroid tissue. However, like surgical interventions, the accuracy of this method can be variable, making it challenging to correlate the dosage of radioactive iodine with tissue destruction. Now, if we turn to pharmacologic interventions, we encounter anti-thyroid drugs, which aim to inhibit the synthesis of thyroid hormones. While propylthiouracil, PTU, is commonly used, in this community, methimazole, tapazole, tends to be favored. Both medications work by decreasing the incorporation of iodine into the thyroid precursors, thus reducing T3 and T4 synthesis. PTU has the added benefit of inhibiting the conversion of T4 to T3. However, it's important to note that neither medication affects circulating hormones immediately. It typically takes about 2 weeks for them to take effect due to the presence of already circulating hormones. Now, let's take a closer look at the adverse effects associated with anti-thyroid drugs. These side effects can be quite concerning, which is why many patients with hyperthyroidism may opt for total thyroidectomy over pharmacologic therapy. Meanwhile, to address other symptoms and concerns associated with hyperthyroidism, we may use beta blockers to protect the heart from sympathetic nervous system stimulation. Pharmacologic interventions such as anxiolytics, sedatives, or hypnotics can help manage anxiety and sleep disturbances. Additionally, dietary modifications, antidiarrheals, may help assist with hyperthyroid-associated diarrhea. Thyrotoxic crisis, also known as thyrotoxic storm, is a rare yet critical condition associated with severe hyperthyroidism that demands immediate attention from healthcare professionals like us, as it can prove fatal within just 48 hours if left untreated. Let me illustrate this urgency with a real-life scenario. Imagine a patient presenting to the emergency room with suicidal thoughts, exhibiting signs of anxiety, confusion, and deep depression. He recounts recent hardships, including a breakup and loss of employment, leaving him feeling utterly overwhelmed, constantly nervous, and experiencing frequent diarrhea, a symptom often overlooked. Despite no history of severe anxiety or depression, these troubling symptoms have persisted for about a week. Upon admission, his vital signs are alarming: a temperature soaring to 104 degrees Fahrenheit, blood pressure surpassing 150 systolic, heart racing in the 130s, and rapid breathing, with oxygen saturation levels remaining stable at 100% on room air. The patient, a 28-year-old male, appears to be in critical state. Now, as nurses, we're trained to scrutinize such presentations and consider various potential causes. While infection or alcohol withdrawal may initially come to mind, further investigation reveals few abnormalities in the initial blood work. Even attempts to manage symptoms with hydration and benzodiazepine yield limited success as tachycardia and anxiety persist. However, a pivotal turning point occurs when a subsequent blood test reveals a markedly elevated level of free T4, indicating a severe case of thyrotoxicosis, a sudden shift in diagnosis from mental health concerns to a life-threatening thyroid disorder. Swift action is imperative. Alongside continued symptomatic treatment, the administration of high-dose corticosteroids aim to suppress the immune response, fueling the dangerous surge in thyroid hormones. This patient's case serves as a poignant example of how undiagnosed Graves' disease can manifest and the critical role healthcare providers play in recognizing and addressing such emergent situations. Without vigilant assessment and prompt intervention, the patient's condition could have deteriorated rapidly, potentially resulting in tragedy. In summary, thyrotoxic storm represents a sympathetic crisis triggered by excessive production of thyroid hormones in undiagnosed hyperthyroidism. Medical or psychological stressors can precipitate this life-threatening surge, leading to a cascade of symptoms including tachycardia, hypertension, hyperthermia, agitation, delirium, and gastrointestinal disturbances. Prompt initiation of supportive care and corticosteroid therapy, coupled with subsequent treatment of the underlying hyperthyroidism, is crucial for successful management and patient recovery. All right, let's sum up the typical presentation of hyperthyroidism. Imagine someone who's always feeling hot despite the weather. They're losing weight without trying and dealing with frequent trips to the bathroom due to diarrhea. They're sweating profusely even when others around them aren't. Their hair is thinning and brittle. They might even have a fast heartbeat, feeling jittery and anxious most of the time. Their hands shake. They struggle to sleep. And for women, their menstrual cycle might become irregular. In essence, hyperthyroidism brings about a whole array of symptoms, ranging from heat intolerance and weight loss to anxiety and tremors. It's like their body's thermostat is set way too high, causing a whirlwind of physical and emotional changes. All right, let's delve into hypothyroidism, focusing specifically on primary hypothyroidism, also known as Hashimoto's disease. Now, this type of hypothyroidism is autoimmune in nature. Here's how it works. antibodies and lymphocytes start attacking the thyroid tissue, causing damage and impairing its function. The presentation of hypothyroidism is essentially the opposite of hyperthyroidism. Patients with hypothyroidism often experience decreased metabolism leading to weight gain, along with feelings of lethargy and fatigue. Their heart rate tends to slow down, bradycardia, and they're more sensitive to cold temperatures due to decreased heat production. In fact, they might even have a lower basal body temperature. Constipation, depression, and heavier or irregular menstrual periods are also common symptoms. The hallmark of hypothyroidism is increased TSH levels because the body keeps trying to stimulate the thyroid to produce hormones, but it's just not responding adequately. This continuous stimulation can lead to hyperplasia or the formation of a goiter. Meanwhile, levels of T3, T4, and free T4 are decreased. Other telltale signs of hypothyroidism include dry, coarse, and sparse hair, along with the loss of lateral eyebrow hair. Myxedema, a buildup of mucopolysaccharides, may occur in various areas like the face, hands, feet, and supraclavicular fossa. This can lead to facial puffiness and dry skin. Patients might also experience a hoarse voice and difficulty swallowing, dysphagia, due to decreased secretions in the pharynx. Impaired concentration and memory, as well as joint pain, are additional symptoms commonly seen in hypothyroidism. Let's delve into the pharmacologic treatment of hypothyroidism, primarily focusing on thyroid hormone replacement therapy. There are two main options available: synthetic preparations such as levothyroxine, Synthroid, or naturally derived desiccated thyroid hormone. While many individuals prefer the more natural option, there are distinct advantages to the synthetic version. Levothyroxine is predictable, providing a precise dose of thyroid hormone per microgram administered, whereas desiccated thyroid's potency may vary, leading to inconsistent results. Additionally, synthetic preparations have a longer half-life, allowing for once-daily dosing and improved compliance. Now, let's zoom in on levothyroxine, the most common form of thyroid hormone replacement. Its supplementation mimics the normal function of the thyroid gland, leading to euthyroidism, the desired state where thyroid hormone levels are balanced. This results in an array of physiological effects, including increased metabolic rate, cardiac function, and renal perfusion. However, it's crucial to maintain the dosage within a narrow therapeutic range to avoid complications. The adverse effects of thyroid hormone replacement vary depending on the dosage. Too little replacement maintains hypothyroidism symptoms, while excessive dosing can lead to hyperthyroidism, like manifestations due to heightened metabolism. However, there are instances where thyroid hormone replacement therapy is contraindicated, particularly in conditions where increased metabolism may exacerbate existing dysfunctions. For example, in heart failure, the increased heart rate induced by thyroid hormone replacement can strain the heart and worsen the cardiac function. Understanding the pharmacokinetics of levothyroxine is essential for effective administration. It typically takes 3 to 5 days to reach therapeutic levels, with peak action achieved in 4 to 6 weeks. While once daily dosing enhances compliance, the longer half-life increases the risk of toxicity. Furthermore, hepatic dysfunction can affect drug binding to plasma proteins, altering its elimination and efficacy. Let's explore central or secondary hypothyroidism, a condition resulting from various pathophysiologic alterations affecting the pituitary gland's ability to produce and release thyroid-stimulating hormone, TSH. Traumatic brain injury, subarachnoid hemorrhage, and pituitary impairment such as tumors or impaired perfusion leading to pituitary infarction can all disrupt TSH synthesis and release, resulting in decreased thyroid hormone levels. Now, let's circle back to myxedema, a term mentioned earlier. Myxedema is a dermal alteration characterized by the infiltration and separation of connective tissues by proteins and mucopolysaccharides, a complex of mucus and sugars. While myxedema is commonly associated with conditions like Graves' disease and Hashimoto's disease, hypothyroid myxedema can be more widespread and severe. It not only affects the face, but it can also involve oral mucosa, leading to symptoms like swelling, slurred speech, dysphagia, and hoarseness of the voice. Moving on to critical complication of severe hypothyroidism, myxedema coma. This represents a medical emergency caused by a profound lack of circulating thyroid hormones. Geriatric individuals with hypothyroidism and comorbid conditions such as infections, heart failure, or stroke are at highest risk. Myxedema coma is characterized by a decreased level of consciousness, hypotension, hypoglycemia, and hypothermia. Interestingly, there's a lack of shivering response despite the hypothermia due to reduced metabolic activity. Hypoventilation ensues, leading to hypoxia and respiratory acidosis. This, coupled with hypoxia, triggers anaerobic respiration and subsequently metabolic acidosis. Without prompt intervention, myxedema coma is fatal. Treatment involves administering IV exogenous synthetic thyroid hormones and providing supportive care to stabilize the patient's condition. In essence, central hypothyroidism and its severe complication, myxedema coma, underscore the critical role of thyroid hormones in maintaining metabolic function and highlights the importance of timely recognition and intervention in managing thyroid disorders. Let's sum up the typical presentation of hypothyroidism. Imagine someone who's always feeling cold despite the temperature. They're gradually gaining weight, battling constant constipation, and their face looks swollen and puffy with dry skin and thinning hair. They're constantly tired, experiencing joint pain, and their menstrual cycle might become irregular. Emotionally, they feel down, struggling with depression, and they find it hard to focus or remember things. In essence, hypothyroidism brings out a range of symptoms affecting various aspects of the body, reflecting the overall slowdown in metabolic processes due to insufficient thyroid hormone levels. Here we have an interesting figure to discuss that contrasts the clinical features of two thyroid conditions, hypothyroidism and hyperthyroidism. I want to draw your attention to a common feature that might initially seem paradoxical, the presence of a goiter, which is an enlargement of the thyroid gland. It occurs both primary hypothyroidism and hyperthyroidism. In cases of secondary hypothyroidism, the thyroid gland actually shrinks or atrophies. This shrinkage is a consequence of decreased stimulation by thyroid stimulating hormone, or TSH, from the pituitary gland. Essentially, the feedback system that normally governs thyroid function is disrupted. Contrastingly, in primary hypothyroidism, even though the thyroid gland isn't producing enough hormones, the level of TSH doesn't decrease. In fact, it's typically higher. This is because the body tries to compensate for low hormone levels by pushing the thyroid gland to work harder, resulting in hypertrophy or tissue growth. Interestingly enough, this hypertrophic response under excess TSH stimulation is similar to what happens in hyperthyroidism. These conditions illustrate the delicate balance of the endocrine system and how it can lead to different physical outcomes based on the feedback mechanisms in place. Understanding these can help us better comprehend how the same gland can appear enlarged in conditions and in both excess and deficient hormone production.